Apologize for this inconvenient connection from the, of course, internet. As I mentioned, I have no any conflict of interest of this presentation. My objective learning, as I mentioned before, allergy is increasing in prevalence and pharmacotherapy alone cannot control the disease. Allergy immunotherapy induces immunological tolerance, changes the course of the disease. Allergy immunotherapy has long-term effects extending beyond termination of treatment. Allergy immunotherapy prevents asthma in children with rhinoconjunctivitis, and allergy immunotherapy improves quality of life in patients suffering from allergy. There's certain definitions. Asthma is a chronic inflammatory disorder of the airways with airway hyperconsistency and airway obstruction. Allergic rhinitis involves a broken or runny nose with sneezing and itching secondary to immunoglobulin E-mediated inflammation of the nasal mucosa. Rhinitis often occurs in combination with conjunctivitis and inflammatory disease of the eye characterized by flushing, swelling, itching, and watering of the eyes. Respiratory allergic disease represents a significant health problem in developed and developing countries. During the past 4 decades, a dramatic increase in the prevalence of allergic disease has occurred, and respiratory allergic disease is now the most common chronic disease among adolescents and young adults. The increase is especially problematic in children because of the prognosis of chronic and frequent aggravating disease. The clinical manifestation of allergic disease, as we know, including asthma, rhinitis, conjunctivitis, anaphylaxis, drug, food, and insect allergy, eczema, urticaria, hives, and angioedema. Respiratory manifestations are the most prevalent, affecting up to 30% of the general population, so it's a bit high percentage. According to statistics from the World Health Organization, hundreds of millions of people in the world have rhinitis, and it's estimated that 235 million people have asthma. So, allergy is a systemic immunological disease initiated by the priming of an adaptive immune response to common allergens. As we see here in this cartoon, the routes of exposure: inhalation, injection, skin contact, and as I mentioned before in the previous slides, allergic manifestation: conjunctivitis, rhinitis, asthma, urticaria, atopic dermatitis, angioedema, and anaphylaxis. So, factors of the development of conjunctivitis as well as asthma, it is becoming increasingly clear that allergy is a systemic immunological disease initiated by priming and adaptive immune response to the common allergens, as I mentioned. Regards the affected organ, allergic disease is characterized by the presence of allergen-specific immunoglobulin antibodies and a inflammation, and also many cascades. The allergic reaction is biphasic, with an immediate reaction occurring within minutes following allergen exposure, and a late reaction occurring hours later, as we know. So this is unsimplified to understand. The immediate reaction is caused by release of preformed mediators from basophils and mast cells upon linking of IgE bond to high affinity receptor on the cell surface. The late allergic reaction is caused by mobilization and attraction of inflammatory cells such as eosinophils, basophils, neutrophils, and mononuclear cells. So, the management of allergic rhinitis and comorbidities, As we know, allergen avoidance is very important, ideally whenever possible. Pharmacotherapy, effective, safe, easy to administer, and surgical intervention in specific cases, and of course, immunotherapy, effective may be change the nature history of the disease. Here, theoretical slide, allergen immunotherapy, known as prophylactic inoculation against hay fever, Lancet in 1911, mentioned allergen immunotherapy is the administration of gradually increasing quantities of an allergen vaccine to an allergic subject, reaching a dose which is effective in improving the symptoms associated with subsequent exposure to the causative allergen. So here, the allergen immunotherapy successful past and promising future from 1880 until now, 2020. Here, the processing from that is coming in new promising future for immunotherapy. Allergen immunotherapy definition, as we know, that therapeutic administration of allergen extracts vaccines to modify or down-regulate the immune response for allergic diseases, thereby ameliorating the symptoms associated with subsequent exposure to the causative allergen. This is an adaptive position paper, of course, of allergen immunotherapy. And also nowadays there is upgrading, updating from WOW, the organization, from IACI, from American Academy, from all international society of allergy. They are supporting this position paper, and also there's a process for evidence to using immunotherapy. And allergen immunotherapy for which allergic diseases, as we know, IgE-mediated disorders like allergic rhinitis, allergen-induced asthma, Hymenoptera phenum allergy, atopic dermatitis, allergies especially, but not for food allergy. There are trials nowadays, urticaria, disorders that are not IgE-mediated. Allergen immunotherapy for which allergies? We know that it's more than 100 years nowadays, and there's a standardized. There's wasp venom allergy, pollen allergens, house dust mites allergy, cat dog allergy, moles allergy, and others. So, allergen immunotherapy proven efficacy in allergic rhinitis and identified effective doses, stabilization, and stabilization duration, resistance of efficacy after stopping, effective in multi-allergen mixes, identified mechanism of action, demonstrates prevention of a new sensitization, and also progression from rhinitis to asthma. Needs and expertise, of course, and training often. The routes of administration, as we know for a long time, there's a subcutaneous slit, sublingual slit, and of course, and skin patches, and there's a new routes of allergen immunotherapy. Here, there's an old position, of course, paper recommended for standardization, clinical trials of allergen-specific immunity for respiratory allergy, statements of word and efficacy of specific immunotherapy is well established. Significant improvement in symptoms of allergic rhinitis and asthma, a reduction in the use of anti-allergic medication type, quantity, and frequency, and reduction of nasal and bronchial allergen-specific hyperreactivity, reduction of immunological inflammatory markers of allergic disease like cytokines, Th2, T helper 2 cells, eosinophils, and tetra, and potential for prevention of natural progression of allergic disease. This is an WHO position paper in 1998, and nowadays there's an updating of this paper. So this cartoon shows how does immunotherapy work. Allergen immunotherapy, as we see, antigen-presenting cells, there's immune diffusion in favor of Th1 differentiation, and T helper 0 to interleukin 12 to T helper 1, interferon gamma, plasma cells, and of course interleukin 10, the other side, induction of the T regulatory cells, and of course that affects cells, decrease in Th2 cytokines, and of course there's an influx of IgG and IgG4 subclass, and of course inhibition of IgE-dependent histamine release, inhibition of IgE-mediated allergen presentation. The mechanisms of action immunotherapy, high-dose antigens, as we see antigen-presenting cells, as I mentioned in the previous slide, and how the interleukin-4 stimulate IgE and allergy, eosinophil, interleukin-5, and T helper 1, interferon gamma, G, antibody G4, and anti-GA. So this is a natural exposure, low dose of antigen and IgE. How soon detected in allergen immunotherapy? Of course, from this cartoon, we can see this within 2 weeks, and we can see introduction after a couple of weeks, late phase response, grass-pollen immunotherapy, interleukin-10 induction and suppression of late response preceding the IgG4 inhibitory antibodies activity. So here in this cartoon by Akdis, of course, the very effects immediate, as we see here, of course, within starting first few hours, weeks, first month, and later on and to the years. Can immunotherapy prevent allergic disease as well as treat it? And we see here the sublingual, the subcutaneous, and also the allergic march from the immunoglobulin antibodies, and of course, all types of allergy. So allergic march is known slide, histological eczema, gastrointestinal rhinitis, asthma, and adult asthma, and how processing, of course, preventing the involvement of a new sensitization. There's an 44 children, 2 to 6 years with asthma, sensitized to house dust mites, 22 children treated with SIT for 3 years, and 22 untreated control group, and SIT can prevent the sensitization of allergic children to new airborne allergen. And preventing rhinitis from turning into asthma in children. So the number of children who had developed asthma within 3 years was significantly higher in control group than in group. So the WHO recommendation mentioned that immunotherapy, when introduced at the onset of during the early phase of the disease, may modify the natural course of the allergic disease. So, long-lasting effects of SLIT in children with asthma due to house dust mite. This is a 10-year prospective study, and also there's another paper mentions more than 10 years post starting immunotherapy. What's the which patient should receive immunotherapy? So there's an WHO recommendation considering of the starting immunotherapy position papers, as I mentioned. So the presence of the IgE-mediated disease is very important. Documentation that specific sensitivity involving symptoms and severity and the duration of symptoms. In asthma control, questionnaire should not show uncontrolled asthma, of course. There's here about the area guidelines. As we mentioned here, there's immunotherapy, as we see here in the stepwise approach. We can see the immunotherapy. There's a place in area guidelines for allergic rhinitis, and also SIT in allergic asthma, specific immunotherapy, as we can mention later on, that's GINA guideline working on therapy for bronchial asthma. Clinical questions, as we maybe it's raising. So now you have learned that immunotherapy is effective, and you have read and hear about all indications and consider. Still ask yourself, should my patient get immunotherapy? Yes or no? Maybe later. Why or why not? So real-life factors to consider when recommending allergy immunotherapy, and it's very important to choosing the time, to choosing the patient, and also the standardized immunotherapy. Who should immunotherapy be recommended to? Patients who are candidates, patients who meet indications. How many indications are needed, which indication are more important, patients who meet qualification, patients who quantifiably need it, patients who prefer it, and how early and also how late is too late. Immunotherapy clinic need to have an provide trained physician up to date, nurses, secretary, education, environmental control, of course, control disease, natural history, concomitant pharmacological treatment at beginning and follow-up, storage for vaccines, it's a very important for a cold chain, skin test reagents, monitoring of patients, compliance, missed doses, of course, to be corrected, dose adjustment, periodic ups or progress, education, reassurance of the patient, personalized attention, and safety procedure, precaution, and management. It must be at your clinic. So there's a future immunotherapy. Of course, the route may be bronchial, epicutaneous, intralymphatic, nasal, or sublingual. All of them they have now, they have trials. Of course, injection, we know the subcutaneous and intradermal, there's an standard extracts nowadays, and modified extract, of course, may immunotherapy, oral immunotherapy, we can add omalizumab, anti-IgE, and of course, there's an anti-LR9 agonist like Tulamba and of course antigens. Of course, the chemical modification, allergoids, there's another forms many companies are working on. Of course, there's an recombinant white type, recombinant hypoallergenic peptides, and now in pipelines, there's a many, of course, still working on. What should you expect from allergen immunotherapy? Improve symptoms, medication, improve quality of life, prevent progression of the disease, prevent new disease, long-term benefits, safe and cost effectiveness, and immunomodulation, restore normal immune response. Is allergen immunotherapy for your patient? So, is it right for your patient? Art and science, approach to the medical decision, clinical judgment based on scientific and medical criteria, along with several pragmatic considerations involving patients, parents, and physicians, and of course, all points I mentioned during my presentation. My concluding remarks, of course, the number of patients with allergies is one of the increased worldwide, and it appears to the current healthcare measures to control this disease are inadequate. One of the actions especially highlights the unique property of allergy immunotherapy to modify the cause of respiratory allergy. Declaration of immunotherapy, focusing on allergy immunotherapy as foundation for the battle against allergy, a public health threat of pandemic proportions. The unique aspect of allergy immunotherapy is the capacity of modify the natural cause of the disease by inducing long-term immunological tolerance. Therefore, future direction immunotherapy should be considered with providing evidence of the different levels of the disease-modifying effects. So today, the only disease modifying treatment strategy for allergic rhinitis and asthma is allergen immunotherapy. So immunotherapy by evidence is that now the modifying treatment strategy. There's an evidence that allergic immunotherapy, allergic rhinitis and asthma, such as reducing symptoms, severity, and infection use, and quality life with a long-lasting effects after the end of the course. The recent clinical trials evidence immunotherapy effectiveness and safety in asthma. Consequently, current version of GINA guidelines recommend allergic immunotherapy as an add-on therapy for asthma. So, this is updating GINA guidelines. There is also evidence that allergic immunotherapy may excrete preventive activity on the possible progression from allergic rhinitis and asthma in children and on the onset of new sensitization, as I mentioned during my presentation. The present review provides a pragmatic summary of the clinical indication of allergic immunotherapy in pediatric asthma and even in other cases, including the immunological mechanism, the markers and stage-free or safety issues in clinical practice. So by the end, thank you for your interest and for your attention. So I'm ready for any question, and thank you and apologize for inconvenient connection due to the technical problems. Thank you very much indeed.
How many professionals are necessary to make more than 100 crucial decisions daily? How many scientists are necessary to develop more than 500 new scientific researches? How many experts are necessary to develop and train new talents joining our company day after day? How many qualified people are necessary to ensure the quality and safety of more than 300,000 boxes of medicine produced every day? We are thousands of employees who understand the criticalness and necessity of medicine in your life and in the lives of your dear ones. Our objective, contributing to the health and well-being of 400 million Middle Easterners, 700 million Africans. Eva Pharma, securing your health.
السلام عليكم، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. سيكون إن شاء الله موضوعنا عن السيدوموناس إن cystic bronchiectasis. طبعا حنبدأ إن شاء الله من حاجة تعريف البرونكيتسيس. هو it's a chronic lung condition defined as an abnormal irreversible dilatation of the bronchi where the elastic and muscular tissue is destroyed by acute or chronic inflammation and infection. This damage impairs the natural drainage of the bronchial secretions, which can become chronically infected, resulting in mild to moderate airway obstructions. طبعا this managed the combination of the infection and this chronic inflammation result in progressive lung damage. Now, patient with bronchiectasis, they characteristically presented by chronic cough with sputum reduction and recurrent infection, and sometimes fatigue and hemolysis. These patients, they may have functional due to reduced lung function or bronchial inflammation and airway obstruction. Now, لو شفنا احنا البريفالنس اوف ان يو كي، طبعا احنا ما عندناش في ليبيا البريفالنس اوف برونكيتس، فلو شفنا ان يو كي من 2004 ل 2012 هنلاحظ ان في 2004 كان عندهم 230 حاله لكل 100,000، بينما بعد 8 سنين 2012 وصلوا 630 ل 100,000 اوف ريجريشن. لو شفنا الجندر او 6 distribution of the bronchiectasis بين الميل والفيميلز، هو اكثر كان في الفيميلز. لو شفنا العدد الميلز كان في 2004 195 لكل 100,000 ووصلوا 281 لكل 100,000 في 2012، بينما الفيميلز they have 265 لكل 100,000 وصلوا 379 لكل 100,000. لو شفنا المورتاليتي ريت دي تو بronchiectasis في 2012 لاحظوا ان البرونكيتس يكونوا حوالي 1.4% مقارنه بالنيمونيا اللي هي 25% تقريبا من السي بي دي اللي هو 26%. لو شفنا البيشنت who has bronchiectasis infected by the Pseudomonas aeruginosa مقارنه بالother patient with bronchiectasis لكن they have no Pseudomonas infection, you find the mortality rate is more in patients with bronchiectasis associated with the infection with Pseudomonas aeruginosa. So this is a very important issue. Now, if we go and see the etiology of the cystic fibrosis bronchiectasis, we find first one is primary infections, bronchial obstruction, aspiration, cystic fibrosis, immune deficiency, alpha-1 deficiency, autoimmune disease, and so on. And if we see the causes of the pathogens or bacteria causing the primary infections and leading to the bronchiectasis, we find infections forming in general as a cause for bronchiectasis is forming in this study about 24% of the patient due to infection. And the most typical organisms that lead to the bronchiectasis by infection is Klebsiella species, Staphylococcus aureus, Mycobacterium, tuberculosis in our country especially, Mycoplasma pneumonia, not tuberculous Mycobacteria, and some viruses like measles, influenza, herpes simplex viruses. And if we see the Pseudomonas as a cause of infection is not causing as a primary infection leading to bronchiectasis, is a very important point. I will repeat again, Pseudomonas is not a primary infection to the lung and doesn't cause bronchiectasis by itself. Now, if we go and see the pathogenesis of the bronchiectasis, we have what we call the vicious cycle, and this usually starts with the infection, with acute inflammation lead to and recruitment of the inflammatory cells. This leads to release of many of inflammatory cytokines, including peroxidases and proteinases, elastase, and so on. This will lead to destruction of the airways, including mucociliary, and damage of the cartilage, supporting the airway structure, and this will lead to the less ventilatory function of the lungs, and this will lead to the impairment of the mucociliary clearance and sputum retention, and this will lead to colonization of bacteria in the airways because it damages the lungs airway, and this leads to formation of biofilm formation, and this from biofilm from time to time see detachment of bacteria and lead to reinfection again, and this go on the cycle. And this is this. If we see the organisms, the airways causing episodic infectious infection, once a patient develops bronchitis, many of the organisms colonize the damaged bronchi and may cause ongoing damage, episodic infectious exacerbations. The organisms found most frequently, most typically include Haemophilus influenzae in this study, and we find Pseudomonas species forming 18 to 26% of the patients. Now, although not the primary cause of bronchitis, Pseudomonas aeruginosa often causes chronic bronchial infection in patients with non-cystic fibrous bronchitis via the biofilm and release of virulent factors. So repeated seasonal infection may promote disease progression and lead to worsening of the lung function and increase morbidity and mortality in these patients. This is one of the studies. They look for they did analysis for patients who have Pseudomonas colonization, and the result with this study conclusion that Pseudomonas is associated with approximately threefold increased risk of death and increase in hospital admissions and exception in adult patients with bronchitis. Now, what is a Pseudomonas? We finished the introduction for bronchitis. Now we'll go and see the Pseudomonas bacteria itself. So what is Pseudomonas aeruginosa? Pseudomonas is a glucose non-fermenting and encapsulated gram-negative bacillus root chip, as we see in the picture. The size of this bacteria is about 0.7 to 2 micrometer. This bacteria is localized in the natural environment, such as the soil and the fresh water, so present everywhere around us. And this bacteria does not show usually pathogenicity in healthy individuals, but it is an opportunistic human pathogen and that lead to a cause infection, mainly in immunocompromised patients or patients who has damaged lungs. So the most common species of the Pseudomonas that cause infection is Pseudomonas aeruginosa. Now, Pseudomonas is well known to cause chronic infection in bronchitis and especially also in COPD patients. And these types bacteria lead to formation of biofilm formation, which is very important for chronic infection. This biofilm is a self-produced polymer matrix consisting of polysaccharides, protein, and DNA. Bacteria are embedded in this biofilm, and the polysaccharide alginate is the major components of the Pseudomonas aeruginosa biofilm matrix, especially in patients with cystic fibrosis. Usually, patients with cystic fibrosis, they have intermittent colonization of the airways, and this is non-mucoid. And when become mucoid due to this polysaccharide alginase, and usually if you have mucoid culture, positive mucoid culture with this bacteria, always to exclude cystic fibrosis in these patients. Pseudomonas also escapes from the host immunity and antibacterial drugs in this biofilm. This is the picture of culture for Pseudomonas aeruginosa on the left side, which is mucoid. So this is this type of the phenotype, which can, if you find it in your patient, always exclude cystic fibrosis as a cause of bronchitis. If you see on the right side, this is non-alginate producing, while the left side is alginate producing. So the non-alginate producing, it is non-mucoid, is a phenotype of type 3. Now the Pseudomonas infection, the impact of the Pseudomonas on the natural course of the disease has been confirmed by its identification as a key determinant of bronchitis severity. I mean that if you have patients with bronchitis and you want to see the mortality and the morbidity of this patient, is it high or low, by using this scoring systems. These two recently developed scoring systems, what we call the bronchitis severity index, one of them, and the other one is the FACIT score. And these two scores to assess severity in patient with bronchitis, they included the culture of the patient and they look for colonization by Pseudomonas aeruginosa, and it's one of the items used in the scoring of the severity. And if you treat the Pseudomonas, this means that the scoring severity will go down. So now this is an example of the bronchitis severity index. You can see it in the slide. So according to this scoring severity index, always we look for patient bronchitis if he has culture result positive for Pseudomonas aeruginosa, because this is one of the items used to assess severity of the bronchitis. That means that they look for the mortality rate in 1 year and 4 years after the result of the culture. Now, the presence of this Pseudomonas aeruginosa infection in patients with cystic fibrosis bronchitis is associated with, that means it's greater impairment of lung function. It will increase the airway inflammation, more frequent exacerbations of the bronchitis, worse quality of the life, greater risk of hospitalization, that written admission to the hospital, and increased mortality rates. So this is very important. We look for Pseudomonas in these patients. Now we come to the treatment of the patient with Pseudomonas. Actually, it's a challenge in managing of patient who has Pseudomonas aeruginosa in non-cystic fibrosis bronchitis. Now, as there is no international or national guidelines for management of Pseudomonas infection in the bronchitis, in this talk we'll use British Thoracic Society and the Spanish Society of Pulmonary and Thoracic Surgery guidelines and expert opinion for Pseudomonas infection management. So in clinical practice, actually, there are 3 distinct clinical situations that present opportunities for managing patients with Pseudomonas aeruginosa infection and in patients with bronchitis. So we divide the management of patients with bronchitis actually in 3 different clinical situations. The first one is at first isolation of the bacteria by the culture. We have to take action. Also, we can manage it during exacerbation, and then we have other opportunity to have another clinical presentation during chronic Pseudomonas aeruginosa infection treatment. So actually, there are limited data available to inform clinicians on optimal management at each point, and there is significant variation among practice. So the English school is different from Spanish schools. So this depends from nation to nation guidelines. They are not in the same treatment. Now, we divide the patient who has bronchiectasis actually clinically in 3 groups. The first group, we have patients with bronchiectasis, and if we do culture for him, we find negative. And the first one, when he come to us, it came positive with Pseudomonas, so we call this is first Pseudomonas aeruginosa infection. This is the first step we can start treatment to attack this bacteria. Now, this culture positivity, it may spontaneously become negative, and then after that may come positive, and so it comes intermittent positive and negative. And one of them, this patient may come with exacerbations. With positive culture, we call this is exacerbation with Pseudomonas aeruginosa. This is the second situation we can see the patient and manage them. The third situation, then, if we manage the patient with exacerbation and then the repeat follow-up, this patient will repeat culture, you may have negative, you may have negative, you may have positive again, and then it spontaneously may disappear, and he received treatment for antibiotic, and then the repeat culture after that may negative. He may have exacerbations, and maybe after that negative. But if stayed the culture always more than 2 or 3 times sequentially, becomes positive persistent, we say this patient, he is in a chronic stage of Pseudomonas infection. So this is the 3 types of patient where we can manage patient with Pseudomonas aeruginosa at first time, positive result of the culture of Pseudomonas, and during exacerbation, and then patient who is stable, but he has repeatedly culture positive, and this is a case of chronic infection. Now, so this is the 3 types. Now we start the management, appropriate management of pseudomonas aeruginosa infection include 3 stages. First, isolation, including eradication protocols. Then we manage them during extubation, and then we manage them during chronic infection, including a long-term antibiotic therapy, either inhalation or oral antibiotic therapy, to reduce the severity of symptoms and frequency of exacerbations. Now, we manage patient first. He came to us, and first time he has culture positive from Pseudomonas aeruginosa. What our clinic next step? So patient who has first time isolated Pseudomonas aeruginosa in the culture, spontaneous clearing of this Pseudomonas infection is not considered uncommon in non-cystic fibrous bronchitis. In one study of Pseudomonas aeruginosa persistent in patients with bronchitis, 34% who were colonized with the Pseudomonas aeruginosa subsequently became culture negative during follow-up without any specific eradication treatment. So some of these patients, they may spontaneously they have negative culture, even he first time have positive culture. Much of the clinical practice involved in managing Pseudomonas aeruginosa in patients with non-cystic bronchitis is derived from studies conducted in cystic fibrous patients. So early infection with the Pseudomonas associated with worse outcomes, and eradication is associated with clinical benefits, including improvement in pulmonary function and reducing of the hospitalization to the hospitals. So if you have patients with bronchitis, when to do sputum culture for these patients? So we do it every outpatient clinic visit, or during only exacerbation, or we do culture once a year, or when the sample is purulent, we do culture. So according to the Spanish guideline, recommendation, we have to do sputum culture every outpatient clinic visit. You have to do culture for every patient with bronchitis. Obtaining sputum culture only during an exacerbation may impair the effective use of past microbiology to guide empiric treatment, because as we know that culture will take at least 3 days. You cannot wait for 3 days. So you will look for the previous cultures and may accordingly you can make choice which antibiotic you can start with it. Obtaining sputum culture once a yearly in this frequency be used only in extremely stable patients. So it's always recommended to do culture every outpatient clinic visit. Although data improvements are limited, studies suggest that eradication of Pseudomonas aeruginosa in bronchitis patients may be associated with improvement in health in some patients. So randomized control trials with a larger patient population will be required to determine the outcomes associated with Pseudomonas aeruginosa eradication following first isolation in these patients. So what is the managed plan for patient? We have first-time isolation of the Pseudomonas. According to the British Society guideline, first line, they start oral fluoroquinolones. And for example, we use the ciprofloxacin, 750 milligram twice per day for 2 weeks. If this fails, then we go second line. We use IV antibiotic like anti-pseudomonal antibiotics like imidazole for 2 weeks, plus at the same time inhaled nebulized, for example, colistin for 3 months. And another second option, if in the second line, you could use inhaled nebulized colistin and use ciprofloxacin instead of 2 weeks, you use for 4 weeks. And you continue inhalation therapy, and according to the British Society, for at least total duration is 3 months. Now, if you go to the Spanish recommendation, the first line in first isolation, they use oral ciprofloxacin for 3 weeks, plus inhaled antibiotic, either colistin or tobramycin, that is continued for 3 to 12 months, which is it's different from the British guidelines. So total duration in Spanish, they use 3 to 12 months and after first isolation of the bacteria. Now, this is a single masked randomized study for eradication therapy for a patient who has cystic fibrosis first-time isolation. They use 300 milligram nebulized tobramycin twice daily and placebo during these 3 months. The result in this study they found in study they found that 54.5% of the patients with who received the drugs they have less exacerbation while they have more. While patient who has tobramycin, they have less exacerbation, that's why 29%. And the only complication with this hair antibiotic is bronchospasm, which is seen about 10% of the patients. And with this result, with this study also, exacerbation and admission and days of admission and days of antibiotic is less than in patients who receive tobramycin in comparison to the placebo groups. Now, when the treatment is considered successful when in the first isolation, judge the success of treatment by both sputum culture and clinical improvement. Sputum cultures are typically performed before and about 4 to 6 weeks after the treatment. It's required for consider a successful treatment at least 2 or 3 negative sputum samples over the next year before considering the patient his bacteria is eradicated. Now, this is the management of patient who has first-time isolation. Now we come to the second group of patients who presented with acute exacerbations. Now, in patients with exacerbation, exacerbations are a significant complication in patients with bronchitis and are associated with reduction in lung function and quality of life. Patients with Pseudomonas aeruginosa infection have more frequent exacerbation and more severe disease in comparison with other bacteria. So what is the definition of bronchitis? So we have to define the exacerbation. According to the British Psychiatric guidelines, define exacerbation that's requiring antibiotic as acute deterioration, usually over several days, with all 3 of the following features. There's increased sputum volume or change in viscosity, increased sputum purulence, worsening local symptoms like increasing cough, wheeze, breathlessness, or they have systemic upset like fatigue and fever. While the Spanish definition guideline define the exacerbation as acute deformment and resistance of changes in sputum characteristic and or increased breathlessness are related to the other causes. So as can we use malfunction and culture for defining exacerbation? Actually, malfunction and culture results may not accurately reflect exacerbation because some patients only have minimal changes in malfunction, although they have exacerbation, and some patients patients may still have chronic bacterial colonization. Now, in these patients who has exacerbation, when we use sputum culture? We should use sputum culture sensitivity for each exacerbation to be taken before administration of antibiotic. And during exacerbation, sputum culture usually is not available, so empiric antibiotic therapy is usually guided by past culture data, and post-exacerbation culture are usually should be repeated 4 to 8 weeks after finishing the treatment. This is the treatment plan for patient with exacerbation. Actually, we divide these patients who has exacerbation in 2 groups: patient who has mild exacerbation and patient who has severe exacerbation. Now, management of patient who has mild exacerbation, we can manage them as outpatient in OPD, and these patients usually have Pseudomonas aeruginosa, ciprofloxacin susceptible. So in British Society, they use oral fluoroquinolones, 5 to 750 milligrams 2 times per day for 2 weeks. And while in Spanish guideline, they use oral ciprofloxacin, 750 milligrams 2 times per day for 2 to 3 weeks. So there is these recommendations are based on limited evidence due to the paucity of data from randomized studies. Now, if you have patients with severe exacerbation, let's say we need to manage these patients as inpatient with admission to the hospital, and these patients, they have respiratory failure, they have distressed. So in British Society, they use anti-pseudomonal antibiotics, combined therapy, either amiranil with the aminoglycoside group, or also this regime can be used for patients with the ciprofloxacin resistant isolates. If this regime failed, the second line, inhaled antibiotics are possible component to the previous drugs. While in the patient who has, according to the Spanish guideline, they use antipseudomonal antibiotics, but the combination, and all for patients who do not respond to the oral therapy. Now, Spanish group, they don't use inhaled antibiotic as an option for treatment observation like the English guideline. So the assessment of clinical response depends on this improving the symptoms and improve in the blood inflammatory markers like the CRB and the white cells. Now, other options for treatment for a patient who has ciprofloxacin resistant Pseudomonas aeruginosa, you could use high-dose ciprofloxacin, you could use augmentin, azithromycin, cholesterol nebulizer, IV antibiotic like ceftriaxone. So all these antibiotics, even not specifically directed at Pseudomonas aeruginosa, such as augmentin or what we call CLAF or macrolides, could change the microbiome and improve symptoms associated with exacerbation. So the inhalation antibiotic in the treatment of observation, actually, as we mentioned before, they have new formulations to use inhaled antibiotic. The first one is ciprofloxacin dry powder for inhalation and DBI, or the other one is liquid combination formulation consisting of solution of liposomal ciprofloxacin mixed with solution of unformulated ciprofloxacin. So the ciprofloxacin dry powder inhaler is delivered twice daily in 1 to 2 breaths, while free liposomal ciprofloxacin is delivered by nebulizer. And the last group of patients for management is a patient who has chronic infection. Now, chronic colonization with Pseudomonas is associated with more severe disease and worse patient outcomes. Although to date, no rigorous clinical data support the benefits of treating chronic Pseudomonas infections, there are strong theoretical reasons for doing so, as well as anecdotal evidence from clinical practice. So, according to the British Society Definition of Chronic Infection, actually they have no definite specified, while in the Spanish guideline, if they have 3 or more positive culture of the same microorganism within 6 months in samples collected at least 1 month apart, this is considered as chronic infection. Now, if you have chronic infection that you will plan to give long-term antibiotic, so what are indications for long-term antibiotic therapy in these patients? Shall we give this patient antibiotic long-term if they have 2 extubations or more per year, or they have 3 extubations per year, or they have 4 extubations per year, or have 5 extubations per year, to decide to give long-term antibiotic, or depend on chronic Pseudomonas infection due to that of the culture, or we don't use long-term antibiotic therapy in patients with chronic Pseudomonas infection. Actually, we decide to give long-term antibiotic in chronic infection if patient has 3 or more extubations per year, or patient who has chronic Pseudomonas infections. Now, preferred treatment for long-term is inhaled antibiotic therapy. For patients who have chronic infection, preferred treatment is inhaled antibiotic therapy. Inhaled antibiotic therapy has the benefit of targeting therapy to the site of the infection. Plus, it allows high concentration of antibiotic in comparison with IV antibiotic therapy, and may therefore work in patients with aberrant resistant patterns seen from the in vitro sensitivity testing. The third reason is you avoid or reduce the systemic side effects if you use for long-term antibiotics. So if you want to give long-term, preferable to give inhaled antibiotic therapy. And the British Society, they give either colistin, tobramycin, gentamicin for 3 months. This is total duration. Actually, total duration not addressed. While in Spanish, they give this inhaled antibiotic 3 to 12 months, depend on how well the infection is controlled. So long-term oral not recommend the resistance and potential side effects. Now, if patient cannot use inhaled antibiotics, so what other options we can use for long term? So the alternative therapy to inhaled antibiotics is macrolides. prior to starting long-term macrolides for safety reasons, ensure the no active non-tuberculous mycobacterial infection with at least one negative respiratory NTM culture. Yeah, if you decide to start macrolide, this is because macrolide is one of the cornerstone treatment of non-tuberculous mycobacteria. And in some studies, the non-tuberculous mycobacteria that leading to bronchitis, in some studies they have 9 or 10% of patients they have this the cause. So you have to screen before you start a macrolides. Use with caution if the patient has significant hearing loss, needing hearing aids or significant balance issues. Consider azithromycin or erythromycin if the patient doesn't tolerate antibiotic inhaler. Consider azithromycin or erythromycin as additive treatment to an inhaled antibiotic for patients who have frequent exacerbation frequency. You could use inhaler with the macrolides at the same time in a patient who has frequent attacks. Now, macrolides for clinically significant bronchitis in adults who should receive this treatment. Actually, in UK, they are using about 20% of patients with bronchitis are receiving long-term antibiotic, while in Europe, they're using 1/3 of the patients they use this type of treatment. It's likely that the beneficial effect of macrolides are a combination of anti-infective and anti-inflammatory properties. Macrolides, when used long treatment, are to date the only agents that have been proven in randomized double-blind placebo-controlled trials to reduce exacerbation in bronchitis. Macrolides. That is just we go through very quickly. We have large study, and they're using the macrolide. This is what we call the BAT study and the BLESS study and IMBRA study. And in BRAS study, they use azithromycin 500 milligram 3 times per week for 6 months, while in BAT study, they use azithromycin 250 milligram daily for 1 year. And the BLESS study, they use erythromycin, erythrosuccinate 400 milligram for 1 year. And if we saw the patient who had pseudomonas aeruginosa, in this study, and the result in patients who had pseudomonas aeruginosa, they found the exacerbation is reduced, and the p-value in comparison to patients who received the antibiotic or patients with placebo is significant p-value. So this means that the macrolide is very helpful in treating of patients with chronic infection. So the macrolide studies have shown clear evidence of reducing exacerbation, which is important to achieve in bronchiectasis. The only problem with macrolides is the side effect. So you have to look for these in your patient. You have to, the most important side effect, GIT side effect, and the hearing impairment. So in hearing, it's advised to do audiometry at beginning, at baseline, and you have to repeat after 3 months, and then after months, during the follow-up, you ask your patient about the hearing problem. Also, there is concern about the cardiovascular effects, and you have to do baseline ECG, and you should exclude QT prolongation. Okay, at the end, we want to improve our management of patients with bronchiectasis who has pseudomonas aeruginosa in our country. Now, this is a problem in our country. There are no international or national guidelines for management of pseudomonas infection in non-cystic fibrous bronchitis to follow. Also, there are national guidelines in many countries for management of this problem, but they have different approaches. Also, we need to have national guidelines for bronchitis management and national registration of these cases. We have this defect, very defect in our country. There are many of cases of bronchiectasis with pseudomonas infection, but unfortunately, there are no inhalation antibiotics, no microbiology department available in governmental hospital like our hospital to look to send the culture for these patients. So to improve outcome of our patient with bronchitis, with pseudomonas, or in general bronchiectasis, is first to have national guideline for bronchitis, and this is the responsibility of Libyan Thoracic Society. And because no inhalation antibiotics, we could use oral macrolides antibiotics in chronic pseudomonas infections, and we want to have available microbiology department we will have pulmonary rehabilitation department. So we have a lot of things we have to look for and to use them to improve our outcome. At the end, I thank you for your attention, and I hope that I give some information to help you on your practice. Thank you.
How many professionals are necessary to make more than 100 crucial decisions daily? How many scientists are necessary to develop more than 500 new scientific researches? How many experts are necessary to develop and train new talents joining our company day after day? How many qualified people are necessary to ensure the quality and safety of more than 300,000 boxes of medicine produced every day? We are thousands of employees who understand the criticalness and necessity of medicine in your life and in the lives of your dear ones. Our objective, contributing to the health and well-being of 400 million Middle Easterners, 700 million Africans. Eva Pharma, securing your health.
Assalamu alaikum wa rahmatullah. Hello everybody, I'd like to present the lung volume reduction surgery in cases of emphysema or obstructive airway disease. What is a lung volume reduction surgery? We call it an LVRS. It's a surgical procedure to remove the disease emphysematous lung tissue. This procedure reduces the size of an overinflated lung and allows the expansion of the remaining functional lung. Patients with severe emphysema. It's a common type of COPD. Patients who suffer from shortness of breath, difficult breathing, and emphysema is a progressive disease caused largely by cigarette smoking, and the disease damages the lungs and makes breathing so difficult. I would like to go for a little bit with the introduction about the lung volume reduction surgeries, which was, as we said, Dr. Otto Brantingen in 1957 was the first person to present the concept of LVRS. He proposed resection of the most useless area of the lung would help to restore the outward pull of the small airway. And in 1995, Cooper and his colleagues modified the Brantigan's lung volume reduction surgery, in which lung tissue was resected from both the lungs via median sternotomy. He reported bilateral LVRS produced 82% of the mean increase in FEV1 and significant improvement in 6-minute walk test. The goal is to remove 20 to 30% of the lung volume by removing the damaged lung tissue and to increase the elastic recoil pressure and to make the patient quality of life better and to relieve the symptom of dyspnea and increase survival rate of the patient and to improve exercise tolerance. Let's talk about who are the candidates for lung volume reduction surgery. Lung volume reduction surgery has been shown to help improve breathing ability, lung capacity, and overall quality of life in selected patients. The effectiveness of this surgery depends on the location or extent of the diseased tissue, as well as the patient's exercise tolerance and the ability to tolerate surgery. Many people who suffer from emphysema have portions of the lung which are more affected than the others. This is what we call it heterogeneous. In lung volume reduction surgery, a large area of the damaged lung is removed to allow the remaining lung tissue to expand. Who are the good candidates? Those who have severe emphysema that does not respond to the optimum medical therapy. and those who are younger than the age of 70, and those who are not been smoking for at least 4 months, and those who have areas of lung which can be removed to improve the lung function through the obtained by the chest X-ray, CT scan, and lung perfusion studies. And those who have other medical conditions which must be controlled, and those who must be able to participate in a pulmonary rehabilitation program prior to and after surgery. Who are the poor candidates for the LVRS? Those who have severely impaired lung function patients with extremely poor pulmonary functions, FEV1 20% or less than predicted, uniform pattern of emphysema throughout the lungs on CT scan, non-upper lung emphysema and high exercise capacity, and those who have certain other serious medical problems. The patient selection according to the National Emphysema Treatment Trial, we call it an NETT. The good candidates for LVRS are divided into 3 groups. Group 1, patients with predominantly upper lobe emphysema and low exercise capacity. They have improved survival and functional outcomes after LVRS compared to the medical therapy. Group 2, patients with predominantly upper lobe emphysema and high exercise capacity. The first group was having a low exercise capacity. Second group have a high exercise capacity with predominant upper lobe emphysema. They have improved only functional outcomes after LVRS, but no difference in survival compared to medical therapy. The group 3, patients with non-upper lobe emphysema and low exercise capacity, those are the third group. Preoperative assessment, we have to do chest X-ray, HRCT scans, quantitative VNQ scan, lung volume measurements, between brackets pulmonary function tests, and maximal exercise testing, which is, we do it by the 6-minute walking test and cardiovascular. These are some emphysema tests. Appropriate to do a lung reduction volume surgery, as here, lung volume reduction therapy for advanced homogeneous emphysema. These are
والله يا شيخ اسمعني من الساعه هذا اللي ماشي بالسوق انا ما نكذبش عليك وانا مصور وانا قدامكم تشوفها دار وفاه تصفيه امورها طيبه. الساعه مني لا انا الساعه هذا هو لان هي قطعه
smaller and allowing them to function better. LVRS can be performed by either sternotomy or thoracotomy or with a minimal invasive technique called thoracoscopy. The surgeon will be carefully evaluating this together with the pulmonologist to approach the treatment for the medical condition to reseal the remaining lung. Thoracoscopy can be used to operate on either sides, unilateral or both lungs, and allows the surgeon to assess resect on any part of the lungs. That makes the thoracoscopy is the best option. Again, summary for the good candidates: those who are having age less than 75 years, ex-smoking more than 6 months, FEV1 less than 45% predicted, dyspnea despite maximum medical therapy, including pulmonary rehab, emphysema with upper lobe predominance, and low exercise capacity post-rehab. We also do bulectomy for those giant bullets who are occupying more than 13% of the hemothorax, severe and or progressive dyspnea despite of maximal medical therapy, PFT evidence of air trapping, CT evidence of compression of the surrounding normal lung parenchyma. Procedure. The LVRS can perform unilaterally and bilaterally. As I said, unilateral LVRS is the best performed with a patient in a lateral decubitus position, which allowing either a standard posterolateral or muscle-sparing thoracotomy or video-assisted thoracoscopic surgery. Bilateral LVRS can be achieved through a median sternotomy, but it's a less option. When performing bilateral surgery, the worst side to operate should be rated first. VATS LVRS is the procedure of choice. That's the position here of the VATS, as you see on the supine position, as you see here in the picture, and how the camera has been placed, and the 3 staplers are putting inside 5mm walking out port, 10mm walking out port. Those are the sites in the fifth intercostal space under the nipple, and there's one at the second intercostal space mid-clavicular line. Those are the best positions for the thoracoscopic surgery. Here we are going to, we have a patient which is a 65 years old patient with a severe pulmonary emphysema, was admitted in our department seeking surgical treatment. As you see, the CT scan reveals moderate heterogeneous illness with predominance on the above areas. These are the CT scan, as you see, the pictures. Perfusion scan, as you see here, not functioning upper fields. And patient was placed in the supine position. It was first on the right side, which is the worst functioning. So we decided to start on the right side. Here, as you see in this video, we started to do a thoracoscopic LVRS. First of all, there was some adhesions between the chest wall and the upper loop, which was carefully dissected to avoid any lacerations on surface of the lung. And while performing the procedure, it was important to use instruments and endo-GIA staplers that deals with lung surgery. The goal is to remove the non-functioning part of the upper loop, which seems to be 60% of the upper loop, and leaving behind as much functioning parts as possible. As you can see, the tissue stapler is resecting 60% of the upper loop, which has been done in our department. It's important to remember that LVRS is not to excise all the grossly diseased lung, but to achieve sufficient volume reduction to improve respiratory mechanics and the function of the remaining lung. The sections, and then the specimen which has been resected is removed by a small plastic medical bag. As you see here in the video. The stapler line is instilled with biological glue to protect it from undesirable air leaks. This is the biological or bio-glue has been instilled in the stapler line, as you see here. One of the best things to protect the lung from air leaks, undesirable air leaks. And chest tube has been inserted. This is the resected piece of the upper loop. And then the left side also has been done for lung function reduction surgery. Left side surgery was similar. Identifying first the upper loop, and then resecting 60% of the upper loop. That means half of the upper loop has been resected, which resembling 30% of the whole lung. This is the tissue stapler. It's been resecting the non-functioning parts of the upper loop. Still resecting this non-functional part, and then has been the resected part was also removed by a plastic bag after a few seconds here. This is the last stapling. Yes, now it has been stapled out, taken out through a plastic bag, the same as was we done in on the right side. Also, we have to apply some, yes, of course, we have to control the bleeding by packing. is beneficial for patients who have predominant upper lobe disease and low exercise capacity as compared with the medical treatment. The outcome measures is the primary outcome measures were mortality and the changes in the FEV1, shuttle walking distance, and quality of life at 6 months. The secondary outcome measures were changes in forced vital capacity, total lung capacity, residual volume, inspiratory and expiratory mouth pressures, and arterial blood gas values. We have also to check the effect of LVRS on resting pulmonary hemodynamic and the right ventricular function. We have to check the effects of the LVRS on diaphragm strength. We have to affect the LVRS on the exercise capacity and dyspnea, and then the effect of LVRS static chest wall function and the effect of LVRS on dynamic chest wall function. The anticipated benefits as overall hyperinflation will be decreased. Diaphragm and chest wall mechanics would improve. Increase in elastic recoil, thereby restoring the outward pull on bronchioles and increase expiratory flow. Increased flow would decrease the dynamic hyperinflation. Improvement in ventilation and perfusion match, which is in turn may decrease when air leaks from the lungs tissue coming from the suture line into the chest cavity. The second risk is pneumonia or infection. The second complication is stroke. The third complication might be stroke, fourth bleeding, and lastly heart attack. We'll talk about the pulmonary rehabilitation. The goal of the pulmonary rehabilitation to reduce symptom disability and to improve functional independence. Most programs is 6 to 8 weeks course of pulmonary rehabilitation prior to LVRS in order to optimize the patient's physical condition and thus avoid any injury from the operation itself. Rehabilitation comprises a number of elements, including nutritional counseling, psychological counseling, and skill training with regard to breathing strategies and management of anxiety. The exercise component includes maneuvers to improve both strength and flexibility, as well as to maximize the lower and upper body aerobic capacity. This entails upper body weight training as well as treadmill work and supplemental oxygen as necessary. Settings is we come to hospital inpatient or sometimes hospital outpatient, community-based and home-based. The component of rehabilitation is about the patient education and chest physiotherapy, endurance training, strength training, respiratory muscle training, physiotherapy, relaxing exercise and energy conservation, nutritional care, and wound care. That's all. Thank you very much.
Thank you very much.
أهلاً بك في الفيديو التعليمي يلقي لك الطريقة الصحيحة لاستخدام جهاز فلوتيفورم HDI الخاص بك. ربما كان طبيبك أو الممرضة أو الصيدلاني بالفعل قد عرض لك كيفية استخدام الجهاز والاعتناء به، ويقدم هذا الفيديو تذكرة لك. لذا فمن المهم أن تحرص على اتباع هذه التعليمات لضمان إعداد دوائك الإعداد الصحيح، وأن يصل إلى رئتيك عند استنشاقه لتحقيق العلاج الفعال لإصابتك بالربو. التعرف على جهاز HDI الجديد. يتكون جهاز فلوتيفورم HDI من مكونات متعددة. يأتي هذا الدواء في عبوة بخاخ توجد داخل غلاف من البلاستيك يسمى مشغلاً، ويحتوي الجهاز على قطعة فموية، ويوجد أيضاً غطاء للقطعة الفموية والذي ينبغي وضعه في حالة عدم استخدامك للجهاز. يوجد أيضاً عداد داخلي للجرعات يشير إلى عدد النفخات المتبقية، ويحتوي الجهاز على 120 نفخة عند الاستخدام، مما يعني وجود علاج كاف في كل جهاز يصلح للاستخدام مدة 30 يوماً. سوف يعد المؤشر عداً تنازلياً كل 10 نفخات بدءاً من 120 إلى 60، ثم يبدأ عداً تنازلياً جديداً كل 5 نفخات إذا تبقى أقل من 60 نفخة. تعني الخلفية الخضراء الموجودة على المؤشر وجود ما بين 120 و50 نفخة متبقية، وبمجرد تبقي 50 نفخة سوف يبدأ مؤشر الجرعة إلى التحول للون الأصفر، وعندما يبدأ المؤشر في التحول إلى اللون الأحمر فهذا يعني وجود 30 نفخة متبقية أو أقل، وهذا سوف يتطلب استخدام جهاز HDI قريباً. ولا تستمر في استخدام الجهاز عندما تأتي قراءة المؤشر عند الرقم 0 حتى إذا ظهر الجهاز كأحد تفضيلات وصفات الطبيب. ينبغي تخزين الجهاز في درجة الحرارة العادية للغرفة. قبل استخدامك لجهاز HDI للمرة الأولى، سوف يعرض لك هذا الجزء من الفيديو كيفية تجهيز فلوتيفورم HDI الخاص بك وتحضيره للمرة الأولى، أو إذا لم يستخدم الجهاز لمدة 3 أيام أو أكثر. لتحضير الجهاز، يرجى إزالة غطاء القطعة الفموية، ثم رج الجهاز جيداً. يرجى إزالة القطعة الفموية بعيداً عنك، ثم الضغط على علبة البخاخ لإطلاق نفخة واحدة، والذي يعرف أيضاً باسم تشغيل الدواء. كرر خطوة التحضير 4 مرات في المجمل، وتذكر أنه ينبغي الحرص دائماً على رج جهازك قبل كل نفخة فوراً، وهذا لضمان مزج الدواء بصورة ملائمة، وأن الدواء قد أصبح جاهزاً للاستنشاق. بعد تحضيرك جهازك، أصبح الآن جاهزاً للاستخدام. إذا تعرض جهازك إلى درجة حرارة التجميد، فيجب تحضيره أيضاً قبل استخدامه مجدداً، وفي هذه الحالة يجب ترك الجهاز ليدفأ في درجة حرارة الغرفة لمدة 30 دقيقة، ثم يجب تحضيره كما هو مبين أعلاه لضمان عمل الجهاز على نحو مناسب. كيفية استخدام جهاز فلوتيفورم HDI. سوف يعرض لك هذا الجزء من الفيديو كيفية استخدام جهاز فلوتيفورم HDI على نحو مناسب لضمان تلقيك الجرعة الصحيحة للدواء. أولاً، يرجى إزالة غطاء القطعة الفموية، ثم تأكد من نظافة القطعة الفموية للجهاز وخلوها من الأتربة. وينبغي رج الجهاز قبل كل نفخة فوراً. ولاستخدام الجهاز، ينبغي وضعه في وضع مستقيم أو الوقوف. أخرج زفيرك بقدر ما يناسبك. أمسك الجهاز في وضع مستقيم باستخدام إصبع الإبهام على قاعدة القطعة الفموية وإصبع السبابة أو بأعلى علو. ضع القطعة الفموية على فمك ما بين أسنانك، وضع شفتيك حولها. ولا تعض القطعة الفموية. تنفس ببطء وبعمق عن طريق فمك، وبعد البدء في التنفس، اضغط على علبة البخاخ لإخراج النفخة الأولى، واستمر في التنفس بثبات وبعمق، ثم احبس نفسك بقدر ما يناسبك، ويفضل ما يقرب من 10 ثوان. في النهاية، يرجى إزالة الجهاز من فمك وإخراج الزفير ببطء، ولا تخرج زفيرك إلى داخل الجهاز. وللحصول على النفخة الثانية، يرجى الانتظار مدة 30 ثانية، ثم تكرار العملية بدءاً من رج الجهاز، ثم استنشاق الدواء، ثم حبس النفس، ووصولاً إلى إخراج الزفير. فهذا سيساعدك على ضمان حصولك على أقصى استفادة من الدواء. وتذكر رج الجهاز قبل كل نفخة فوراً. يرجى استبدال غطاء القطعة الفموية بمجرد أخذك لجرعة الدواء، وتذكر أن الجرعة المعتادة هي استنشاقان 2 يومياً، أي 2 في الصباح و2 في المساء، وهذا إذا أردت.
بعنوان IgE and severity of bronchial asthma. IgE and severity of asthma. Patients with severe asthma represent only 5 to 10% of the total number of subjects with asthma. This small population, however, consumes about 50% of the global asthma budget due to exacerbation, emergency room visit, investigations, and pharmacotherapy. Well, we have realized that bronchial asthma is not really a single disease, but it is a mix of many aspects of growth. Phenotypes can be classified either according to manifestation, airway obstruction, and asthma in obese subjects. Now, also can be classified according to induced or triggers. It can be either allergic asthma, occupational asthma, exercise-induced asthma, or aspirin-induced asthma, or asthma in smokers. The other classifications, either eosinophilic asthma or neutrophilic asthma. Now, this cartoon shows the immunological mechanism that occur in asthma and trigger the reactions. Here, you can see this is the respiratory epithelium and the antigens, whether it is pollen or animal or food or whatever, it enters the epithelial layer and it is received and captured by the macrophage or dendritic cells. And then the antigen is attached to the dendritic cell and combining or bridging two molecules of IgE. And as a result, after the antigen is processed, it stimulates Th2 lymphocytes, which in turn produce cytokines in the form of IL-4, IL-13, and these in turn stimulate the B cells, which mature into plasma cells and produce specific IgEs against the allergens or the antigens. Now, these antibodies attach to the surface of mast cells and basophils, and they bridge when the patient is exposed to allergens. One allergen bridges two molecules of the IgE, which stimulates the cell to produce a lot of chemicals and cytokines, such as histamine, leukotrienes, prostaglandin, and cytokines L13 and IL-14, which in turn triggers the inflammatory process in the smooth muscles and the mucous membranes of the airways. Another pathway is that Th2 produces IL-5, which stimulates the eosinophils, and these produce leukotrienes and cytokines, which in turn cause inflammatory changes in the epithelial cells and the smooth muscles. IgE and severity of the asthma severity has been assessed with a combination of subjective, such as daytime and nighttime symptoms, and by objective measures, including the use of rescue medications for flare-ups and spirometry measurements and peak flow meters. The patient, but sometimes the FEV1 and the spirometry does not reflect the real condition of the patient. For example, patients with FEV1 less than 30% may reach normal lung function when they are treated, while patients with FEV1 of greater than 70% may continue to be symptomatic. Specific IgE levels of common aeroallergens are much better markers of atopy than the total IgE levels. We have many patients with asthma may have normal IgE level, but when we measure the specific IgE, either by skin test or in vitro testing, we find the IgE is elevated. Studies in the Western population, as you remember, the IgE level differs in different populations. For example, in India, all patients, even when they don't have symptoms, they have very high level of IgE, and the same thing in Africa. This depends on the hygienes and the parasites available in the environment. Now, this study represents the Western population, and they found in adults that the normal range of IgE is 40.8 international units per ml, with the range of 15.5 to 114. And in children, usually it is higher, 106 with the range of 1.5 to 112. In a large study, found association between the level of total IgE and severity of bronchial asthma. Now, this is one study in children who have asthma and allergic to dust mite. And this is correlation of asthma severity and serum IgE in asthmatic children sensitized to dermatophagoides terrosinus. This study included 157 children with asthma, their ages between 5 and 15 years. The diagnosis was based on personal and family history, physical examination, pulmonary function test, and skin prick test, in vitro test, total and specific IgE. The asthma severity was determined according to the GINA guidelines. Now, the present study showed that patients with total IgE concentration of greater than 288 kilunit per liter, with a specific IgE to dust mite to be greater than 44.1 kilunit per liter. You notice there are two measurements, either international unit or kilo unit. A positive predictive value suggested with 79.2% probability that a child with a concentration of specific IgE to dust mite 44.1 kilunit per liter would have a more severe bronchial asthma. The conclusion from this study that asthmatic children with higher asthma severity have a higher serum concentration of both total IgE and specific IgE. This is another study which patient with high IgE had a lower mean FEV1% of predicted than with patient with asthma with low IgE, regardless of race or ethnicity, respectively. The p-value less than 0.31 and less than 0.001, very highly significant. 54.7% of the patients with asthma with high IgE had been previously hospitalized, compared to with 44.1% of patients with lower IgE. I have to go down to the original study, which actually it is an epidemiological study in three major groups: African American, Mexican, and Puerto Rican. And it included 4,756 cohort patients with severe and or difficult to treat asthma. And the purpose of the study was to examine the relationship of IgE to physicians' evaluation asthma severity. The study extended over 3 years, and it included patients between 6 years and above. The mean total IgE level of the population was 106.6 international units per ml. Children 6 to 12 years old and adolescents, the level was higher than adults with p-value of 0.001. Males have a higher mean IgE levels than females, and IgE levels are higher amongst non-white patients than with white patients. And the current smokers have higher IgE level than past smokers or never smoke. Among children, patients with severe asthma have a higher mean IgE level with a value of 280 international unit per ml than patient with moderate 145.8 units or mild 137.8 asthma with a p-value of 0.001. Among adults, patients with childhood onset asthma have higher IgE levels, 124.3 in 1,348 patients, than patients with adult onset asthma with the level is 6.7, and the number was 1,956 with a p-value of less than 0.001. A patient with high IgE had a lower mean FEV1 predicted of percent of predicted than with patient with asthma with low IgE, regardless of race or ethnicity. And 54.7 of patients with asthma with high IgE had been previously hospitalized compared with 44.1 of patients with lower IgE. The conclusion is that among patients with asthma from 3 ethnicity groups, total IgE levels are reversibly correlated with the baseline lung function and asthma severity. Now, in this table, it is comparison between those patients who had high IgE levels and those who had low IgE levels. Here, the asthma severity, moderate to severe. Those who had more than 100 units were 492 patients, and 72.2 they had severe asthma compared to those who had level less than 100 with a p-value of 0.1. Now, diurnal symptoms were not different actually in the two groups, and nocturnal symptoms also the same. However, those who have PITS, they have more severe asthma compared to those who had low IgE. And hospitalization was more frequent in patients who had high IgE compared to those who had low IgE. Now, comparison of lung function between the asthmatic with high and low IgE levels is shown in this table. The asthmatics with high IgE, FEV1 is 87.6%, while those who had low IgE, it was 91.5 with a p-value of 0.0058. FEF, the small airways, it was 25 to 75. It was 68 compared to 78 with a p-value of highly different between the two groups. And FEV1 by FVC was 84.2 in the high IgE, while it was 93 in those who had low IgE. So the serum IgE levels in a large cohort of patients with severe asthma or difficult to treat is shown here. Epidemiology and natural history of asthma, outcome and treatment regimen, 4,756 cohort of patients with severe and or difficult to control asthma. This is to examine the relationship, as I mentioned earlier. Now, the results were mentioned. The conclusion of this large cohort study in different ethnic groups with high and low IgE level in patients with severe or difficult to treat asthma from the Tenor study, higher total IgE levels were observed in males, children, smokers, non-white racial ethnic groups, and adults with childhood onset of asthma. In addition, IgE levels are associated with asthma severity among younger patients. Now here is another study which compares the relevance of skin test, whether it is positive or negative, to the severity or difficult to control. Now, skin prick test is considered the gold standard for detecting allergen-specific IgE in the clinical setting and are an important tool for diagnosis and managing allergic asthma. The objective of the study was to assess the relevance of skin testing in patients 12 years or older. It included 2,985 patients who were eligible, and 85.8% they recalled that they were skin tested positive. 93.5% were positive, and the total serum IgE was 104.6 international unit for those who had skin test positivity, and it was 32.4 units for patients who were skin test negative. These data support the utility of a more complete allergic evaluation in severe asthmatics. Skin testing appears to be associated with disease physiologies in asthma. Thank you. نعم. دقيقة من فضلك.
Thank you.
أهلاً بك في الفيديو التعليمي القصير الذي سيعرض لك الطريقة الصحيحة لاستخدام جهاز فلوتيفورم HDI الخاص بك. ربما كان طبيبك أو الممرضة أو الصيدلاني بالفعل قد عرض لك كيفية استخدام الجهاز والاعتناء به، ويقدم هذا الفيديو تذكرة لك. لذا فمن المهم أن تحرص على اتباع هذه التعليمات لضمان إعداد دوائك الإعداد الصحيح، وأن يصل إلى رئتيك عند استنشاقه لتحقيق العلاج الفعال لإصابتك بالربو. التعرف على جهاز HDI الجديد. يتكون جهاز فلوتيفورم HDI من مكونات متعددة. يأتي هذا الدواء في عبوة بخاخ توجد داخل غلاف من البلاستيك يسمى مشغلاً، ويحتوي الجهاز على قطعة فموية، ويوجد أيضاً غطاء للقطعة الفموية والذي ينبغي وضعه في حالة عدم استخدامك للجهاز. يوجد أيضاً عداد داخلي للجرعات يشير إلى عدد النفخات المتبقية، ويحتوي الجهاز على 120 نفخة عند الاستخدام، مما يعني وجود علاج كاف في كل جهاز يصلح للاستخدام مدة 30 يوماً. سوف يعد المؤشر عداً تنازلياً كل 10.
السلام عليكم. This presentation is about chronic cough in children, a mistaken identity and wrong management. Actually, this was based on observation that many patients were referred to our center complaining of chronic cough, who were treated with nebulization with no improvement, and they were treated as asthmatics. And I will start the background by presenting classical cases which were mismanaged and misdiagnosed. The first case is Ruba, 12 months old. She had cold-like cough, phlegm, hoarseness of voice, wheezing sometimes since the age of 4 months. She received several courses of nebulization with salbutamol and budesonide and montelukast with no much relief. She was found to have multiple food allergies. She had both nasal and postnasal discharge. Sinus X-ray showed total opacification of both maxillary sinuses. 2 weeks treatment with clarithromycin led to asymptomatic happy child, and follow-up she had no cough. And this is her X-ray. Some physicians believe that children, younger children and infants, they don't have sinuses or they do not develop sinusitis. The truth of the matter is that ethmoids, and maxillary sinuses are developed at birth. So you can see on the right side here, the maxillary sinus and the ethmoids are totally opacified. 2 weeks of treatment, the child developed normal aeration of the sinuses. In the beginning, before we had our X-ray machine, I used to refer them to a radiology center specialized in diagnosis. And I send the infant or the child, and the report comes back, the sinuses have not developed. And then after treatment, I send the child again, and they said now the child has sinuses. So sinuses cannot develop in 2 weeks. And they start to change their report. Case 2, Ali is a 6-month-old baby with noisy breathing, cough, rattling in the chest, wheezing sometimes, restless sleep. He received nebulization at home with bronchodilators with minimal improvement. Waters X-ray showed total opacification of both maxillary sinuses. Treatment with antibiotics, anti-inflammatory, resulted in aeration of the sinuses, and he became asymptomatic with no need for bronchodilators after 4 weeks. And this is Ali's X-ray. You can see in this X-ray here, the sinuses are not apparent. And here, after the first 2 weeks, there was partial aeration of the right maxillary sinus. And then after 2 more weeks, sinuses became fully aerated. Case 3, Saud is 2.5 years old with 18-month-old history of wet cough, choking, especially at bedtime, nasal congestion, and noisy breathing. Adenoidectomy was done at the age of 2 years with minimal temporary improvement. He received mometazone and salbutamol inhalers, antihistamines, and short courses of antibiotics, but he continued to suffer from cough. His mother noticed that he has bad breath. X-ray of the sinuses showed opacification of the maxillary and ethmoid sinuses. He became asymptomatic after 2 courses of antibiotics, 2 weeks each, and sinuses became aerated. And this is his sinus X-ray. Here you can see the maxillary sinuses are almost full with minimal aeration, and in the left ethmoid, minimal aeration in the right ethmoid. Here, the X-ray after treatment. Case 4, Nasser is a 7-month-old. He had cough, congestion, restless sleep, rattling, choking, noisy breathing for the preceding 8 weeks. Bronchodilators by nebulization did not help. Waters X-ray showed total opacification of both maxillary and ethmoids. Treatment with clarithromycin for 2 weeks led to the aeration of the sinuses and clearance of the symptoms. And this is his sinus X-ray. You can see total opacification here, ethmoids and maxillary, and now it is fully aerated. Now, the cause of chronic cough in children is multiple. So, definition of chronic cough is defined as a cough lasting more than 4 weeks. Most acute respiratory infections in children resolve within times. Some reports define chronic cough as that cough which lasts 8 weeks or more, although chronic cough can start at 4 weeks and continues. The diagnosis of chronic cough in children requires detailed history, physical examination, chest radiogram, sinus radiogram, spirometry in children older than 4 years, and blood count. The classification of chronic cough in children is due to the cause. Number 1 is either specific cough, such as asthma, persistent bacterial bronchitis, a chronic suppurative lung disease, bronchiectasis, airway abnormalities, aspiration, and less common infections, interstitial lung disease, and extrapulmonary causes. Non-specific cough, such as cough is dominant asthma, increased cough receptor sensitivity, habit coughing in about 10% of the cases, and autogenic cough, which is rare. Children with ear infections, sometimes they present with cough. The epidemiology of chronic cough in children is about 5 to 7% is in preschool age children and 12 to 15% in older children. It is more common in boys up to the age of 11 years, and then after that, the sexes are equal. The upper airway cough syndrome, it is the underlying reasons for postnasal drip includes allergic rhinitis, perennial non-allergic vasomotor rhinitis, and sinusitis. The approach to chronic cough in children, number one, cough is an important defensive reflex. Healthy children may cough on a daily basis. It has been reported that they can have 11 episodes of cough in 24 hours without having any pathology. The cough may indicate an underlying pulmonary or extrapulmonary disease. The diagnostic approach is number one, to know the nature of the cough. Is it chronic paroxysmal, triggered by exercise, cold air, etc.? This suggests bronchial asthma or reactive airway. Barking cough or brassy cough and staccato cough in young infants usually indicates chlamydia infection. Honking cough is usually psychological. I have seen quite a few of these cases. Usually it disappears during sleep. It becomes worse during school if they are school-age children. And chronic productive cough, which indicates some kind of infection in the lung. Now, the timing and trigger of cough, bronchial asthma, nasal change of position. If the child coughs when he changes the position during sleep, then we have to suspect nasal source of the cough. Bronchiectasis is usually worse in the morning, and swallowing, aspiration, or anatomical defect. And if the cough increases during the supine position, we have to suspect GERD. Psychocough is during the day and school and disappears when the child is asleep or when there is a holiday and no school. The past medical history is very important. Family history. Those who have family history of allergic rhinitis or bronchial asthma or others, the cough has to be suspected as secondary. The mental history and exposure, medications, and sinus imaging. The associated factors in children with chronic cough include, this study is in 40 children, 5 to 12 years old, younger than 5 years were not included. It was found that gastroesophageal reflux was in 27.5% of the cases, and allergy was the underlying cause of the chronic cough in 22.5%, and asthma as a cause in 12.5%, infections in 5% of the cases, and aspiration in 2.5%. Multiple etiologies were found in 20%. The Waters View sinus X-ray use is useful in evaluating chronic cough in kids. Now, this study was presenting for the first time in the American College of Allergy annual meeting in 2010. The study including 100 children, 3 to 18 years of age, cough, 3 to 12 weeks duration, and 70% of them, they had abnormal water view and radiology. And these are some of the cases, show a pre and post treatment. And you can see this child with total opacification of the sinuses, and here they are fully aerated. A recent study from the National Center of Allergy, Asthma and Immunology in Riyadh, we evaluated between 2007 and 2012, we evaluated 416 children. Their ages ranged between 4 months and 18 years. The average age was 5.2 years. The evaluation was by history, physical examination, CBC, serum IgE, skin prick test, spirometry in children who were older than 5 years, and sinus X-ray. The symptoms in those children, cough only was in 223, and bronchial asthma and sinusitis in 157, and there was no specific cause in 7 cases, and other causes in 9 patients. Sinus X-ray, maxillary alone was positive in 235 patients, and maxillary and ethmoids in 84 cases, and maxillary and sphenoid in 60 cases, and maxillary and ethmoid and sphenoids in 16 cases, ethmoids and sphenoids in 5 cases, and maxillary and frontal in 4. This is usually in children who are older than 5 years, and adenoids in 43 and 22 cases, the X-ray was normal. 106 patients responded from the first course of antibiotics, while 158 we had no follow-up. Usually when patients improve, they do not show up and they don't keep their appointment. And 59, they had partial clearing of their sinus infection after the second course. And 54, they were non-responders. When you take the history of these children who do not respond, usually they had several courses of antibiotics. So the organism becomes resistant. The characteristic of symptoms in children with sinus with barking cough. It is early at night, usually in the first hour after sleep. Rattling in the chest, snoring or mouth breathing, frequent clearing of the throat in older children, halitosis, headache, colored nasal or post-nasal discharge, sometimes with blood, symptoms of allergic rhinitis and or bronchial asthma, restless sleep with tossing of the head in infants and young children. Now, if a child has most or some of these symptoms, we have to suspect that the underlying cause of his cough, her cough, is sinusitis. Now, in summary, sinusitis is a common cause of chronic cough in children. Maxillary and ethmoid sinuses are developed even in infants. Maxillary and ethmoids are the most commonly involved. Sinusitis is commonly associated with allergic rhinitis and bronchial asthma. Many children with a chronic cough are misdiagnosed and treated as asthmatics. Always look for sinusitis in children with a chronic cough, especially if they are allergic. Sinus X-ray should be considered in children with a chronic cough, especially if the child is asthmatic or has allergic rhinitis. Treatment with antibiotics for 2 to 6 weeks with or without short course of steroids and decongestant results in dramatic relief. Always think of sinusitis in a child with a chronic cough. Thank you.
Yes, sir.
Any question? Thank you.
ستوب شيرينج. هو خليني نطفي المايك.
بسم الله الرحمن الرحيم، اهلا وسهلا. خالد الهديلي، استشاري امراض صدريه في الولايات المتحده. حنتكلم اليوم ان شاء الله على اعراض الرئويه لكوفيد 19. Next slide. Next slide. Okay. Oh, you went back. Okay. As we are going to talk today, it's a good thing to have a reminder of the structure of the virus itself. As you all know, it's a RNA virus, as you can see in the cartoon, starting with the 5' ending in the multiple amino acid primes. And other important things that need to be remembered in the structure of the RNA polymerase that acts on the breakdown, as we will show in a second, and the protein that we need to focus on is the S protein. Next slide. This is how the virus infects the body. These are the virus attached to the ACE2 or receptors on the or in the lungs, and by either fusion or the virus goes into the cell, releasing RNA acted on by the ribosomes, producing first the negative, then the positive copy of the virus that goes to the into the reticulum and into G bodies, and the proteins are reassembled again and producing multiple other copies of the viral. So this is a simple cartoon showing how the virus gets out replicated within the body. Next slide. Okay, now this is a quick cartoon showing, first of all, can you mute the background because it's interfering with what I'm saying? Sorry. Thank you. Okay, now we'll talk about that transmission. How is it transmitted? This is everybody now knows this. People will sneeze, will cough, will sing, will talk. After that, the infected patient will spread the viruses. Most of the virus particles are big enough that they will drop immediately, but a significant amount can go beyond just dropping to the next person if that next person is about 6 feet or less. However, with the right singing or screaming, the viron can reach up to 9 feet or even more. We will talk about this a little bit later, but there are special situations that makes transmission even worse by making the particles smaller, and that is during intubation, especially with the use of vapotherm, CPAP, nebulizers, and with bronchoscopy. All these procedures are a high risk for transmission because they make the particle much smaller. Next slide, please. This is a quick reminder. Everybody knows this by now. 80% of people would have mild to none symptoms, 15% severe, 5% severe enough that takes them to the hospital. Half of the 5% would die in the ICUs. Next slide. This is a good study that actually showed us how asymptomatic transmission works. The index patient is a patient in the conference, a Chinese patient in the conference in Wuhan. Patient number 1 is the patient who was with him in the conference, and apparently he got infected when the index patient was asymptomatic. He went back to Germany and he was able to infect other people's patient 2, 3, and 4 who did not attend the conference. And this is a good example of a asymptomatic transmission. Next. Another point I would like to talk in this regard is the fact that the PCR that we test right now, and everybody knows everybody knows about it, it stays positive for 6 weeks. However, 2 groups in Germany and Canada did a daily culture of the people who are infected in small series, and they found out in day 8 to day 10, they start to not grow the virus. In other words, the virus is no longer infectious at that time, and the PCR remains positive up to 6 weeks after the initiation. So patients who are asymptomatic can shed the virus for 6 weeks, yet they are only infectious for 8 to 10 days. This is an important role. That's why I always discourage from repeating the PCR just to prove that the patient is cured. Next, please. This is another slide of infectivity. People who are symptomatic and got diagnosed with COVID, after 10 days, provided that the last 3 days of those 10 days are afebrile and other symptoms improved, then he should be considered as non-contagious and he can get out of isolation. The people who get tested because they are contacts who have no symptoms, we count from the day of positivity, so the PCR is positive 10 days later, and then they are considered as a non-contagious. Next. Those are the conditions where the bad outcomes usually happens. Obese people, diabetics, hypertensives, cardiac diseases. But interestingly, people with lung diseases like asthma and COPD did not show an increase in the bad outcomes as we initially expected. Next one. This is the obvious issue that we pulmonologists deal with, is the hypoxemia. As we all know, there is a hypoxemia that carries a normal alveolar arterial gradient, and this is typically the hypoxemia that is not a part of COVID. This is in people who would have hypoventilation, for example. Patients who have increased AA gradients, that is how the hypoxemia in COVID works. It's either VQ mismatch, which can be corrected with simple oxygen cannula, or as the disease progresses, if it's going to get worse and start to having the fibrotic portion, it's going to start to bring shunts, and those are the people who will usually require mechanical ventilation. Next. This is a study that came out about 10 days ago. This, after all these months, we now are characterizing the lung involvement in COVID to 2 phases. And then here we are talking about severe COVID pneumonia, not all COVID infections. So COVID pneumonia, early phase is the phase of viral replication. This is the phase that presumably remdesivir works, even though now there are studies to suggest that remdesivir does not change the overall outcome, except in some people. And this is where the immune response happens. So early in the pneumonia, this is what we see. Late in the pneumonia or late phase, the viral or the virus cannot be cultures, and the lung is showing damage and fibrosis. Interestingly, the study also showed that viral replication happens in the nose, not in the lungs. This is interesting now that we have the vaccine that actually acts on the ACE2 and receptors, as I showed a second ago. Those people who get the vaccine will get the protection themselves, but they still can carry and spread the virus because the virus replicates in the nasal passages, not in the lungs. Next slide. Okay, so in the European Respiratory Journal, they sort of looked into groups of people who got COVID infection and looked at the different pulmonary problems they sustain, and they found that there's usually a low DLCO, there's a small airway disease, and there are ground glass opacities. There's also decrease to the total lung capacity, but that did not reach a significant statistical significance. Next, please. When we're talking about ground glass, about 40% of people on 6 days after infection would get some sort of opacification at least, and about 70% of the people would get that in 11 days. The opacification itself starts in the early stages with a pure ground glass, like we see in the upper right picture, and later on it starts to form some consolidations and still some ground glass, but more of organized consolidation and scarring. The last picture is the late stage. Those are the people who are by now are in ventilators, and they show extensive scarring and opacification. As you can see, you can also see some ground glass at the same time. Next slide, please. 60% of the people on discharge who have changes, 60% of that change is a pure ground glass, is a ground glass, and 70% of that 60% are pure ground glass opacification, and the rest are spread as you can see in this cartoon. Next. Now we'll talk a little bit on the specific scenarios and specific pulmonary related. These are the things that when they consult me as pulmonologists and patients with COVID, these are the things I look at. And I just picked up a couple of studies here and there. There are a plethora of studies that sometimes are even conflicting, but I just chose a couple of studies to try to elaborate more on specific pulmonary involvements in COVID. Next slide, please. This is a study interestingly published in Cardiology Journal. This shows the risk to healthcare providers from COVID, and unfortunately, this is a risk that was concerning early in the disease, and we don't see as much late in the disease as we did. And this is the people, the nurses, the doctors who get infected. Unfortunately, when they get infected, they have severe infection because of the proximity, because of the sickness of the people they're dealing with, because of using maneuvers like intubation. Intubation, you're pretty much opening a freeway from the lungs to the doctor's face. So the dose of infection is high, and that's why doctors and nurses, when they get sick, they get really sick. This study actually showed that 10% of the people in the study of the doctors and the nurses in the study showed symptoms of COVID, but only 3% of them actually tested positive. And adding the negative positive, of course, the percentage could be more. And fortunately, we're not seeing as much lately. Next slide. This is a study talking about the other side of intubation, is these people who come in, and this is the debate that is still going on until now. If I see a patient, is it better for me to delay intubation or should I intubate early? This is a debate among critical care doctors even before COVID. What is safer? Should we intubate and rest the patient, or should we let the patient try to get himself out of this trouble without intubation? The collective anecdotal opinion is try to delay as much as you can and using other measures, as I will talk in a second. But this study, interestingly, is showing that the time of intubation does not affect mortality. And next slide, please. This is the recruitment. Basically, they ended up they're starting 730 patients, and then they randomized them as 109 to receive high flow oxygen, and about 78 doctors as or patients as intubated immediately. The people who get the high flow oxygen, some of them actually failed and got intubated. So finally, 175 people got intubated, and 63 of them died. Next. Of the 63, as you can tell here, patients, 29 of them were intubated less than 8 hours after admission to the ICU, and 18 of them were intubated between 8 and 24 hours of admission to the ICU, and about 16 were intubated after 24 hours. Now, among all these three groups, the length of stay in the ICU and the duration of ventilation, as you can tell here, is not different at all. None of them have any statistical significance. So this study tells us whether you intubated early or not, the mortality is going to be the same. But again, it's still my opinion that we do try to delay as much as possible. Next slide. Okay, this talks about the nebulizers. I didn't show the summary or the conclusion of the study, but in summary, nebulizers make the big droplets, tiny droplets, makes the droplets hang on the in the air for 3 to 4 hours after nebulization. So my job when I get consults is I'm going around changing everybody, whether they're in COVID floor or not. I change everybody from MDI, from nebulizers to MDIs. I do not like to use nebulizers at this time as much as possible. Also, the recommendation here is the questionable modalities or questionable treatments that we use sometimes, like the NAC or the hypertonic solutions in certain situations. Those should be avoided. To start with, they are not significant, and we are just using them like throwing the sink on somebody because we tried everything else and didn't work, and they should be avoided during these times of COVID. So try to not use nebulizers during the COVID era in the hospitals. Try to use only MDIs, and that also goes for CPAP. Of course, unfortunately, we cannot, because CPAP and Vapotherm are modalities that we have to use to treat people with COVID, but we need to use it with extreme precautions. Next slide, please. Okay, this is an interesting maneuver that has been done since the last century. an Italian professor who was saying, well, on those people who have bad pneumonia as an ARDS, how can I improve their oxygenation? I give them oxygen 100%, I put them on a ventilator, and they are still not oxygenating. So what he did is he thought that when we increase the pressure inside the lung, which is the auto-PEEP, that might improve recruitment and improve oxygenation. So he started by actually putting bricks on people's chests while they are ventilated, and he did prove that the oxygenation improved. After that, people said, well, we don't need to go that crazy. So instead of putting bricks, they just flipped people and put them in prone position. And consistently, or at least mostly, people would improve. So there's significant improvement. And we have seen a lot of improvement in the past when we use it on ARDS. The only problem and the reason why this didn't take is because study after study failed to show improvement in survival. So whether you prone them or not, whether you improve their oxygenation early or not, it didn't seem that this modality or this maneuver changed mortality. So people are using it on their own discretion, not as a part of protocol, for example. Next slide. This is a study in a journal, basically looking at proning and manipulation of PEEP with patients with early COVID ARDS. Next page, please. Basically, it is consistently, whether in the first proning or the second, third, fourth proning, there's always improved in oxygenation, as you can see by this cartoon that shows in the left the first day, in the middle multiple follow-up days that they prone. Many maneuvers when you do there's seems to work in the beginning and doesn't work later, but this one consistently, every time you prone, you improve. And overall, the last graph there show a significant improvement. Next slide, please. This is another thing that we see with COVID that is related to the lungs is the prevalence and the increase in incidence of the thromboembolism in patients with COVID. Dr. Beccadelli in New York, when they had the big surge over there earlier in the pandemic, said, I've never, ever seen D-dimers as high as I have seen in people with COVID. And it is consistently observed in people. Sometimes there are studies where they dissected at least 10 or 15 patients, and the pathologist said there's significant thrombus and clot formation in all 10 of them. So this is a well-accepted phenomenon. The point I wanted to allude here is I am following many patients in Libya over the last several months. The more common question I get that doesn't make sense for many people is, hey, my D-dimer is high, what should I do? The D-dimer is an acute phase reactant. It have a good negative predictive value. So if your D-dimer is 0 or low, chances of you having a clot is very low. However, positive does not mean anything out of the context. So you have to be sick in the ICU with high positive for that to mean that you probably do have a clot and you should do a CT scan with contrast or VQ scan. But people who just got diagnosed and still not even on oxygen should not even do this test. And also people who recovered, I got many people who recovered and still checking D-dimers and still asking if they should be on anticoagulation, and that's wrong. This is an acute phase reactant that should be used in context. Next slide. This study in Lancet is talking about steroid. This is still a controversial point. Steroids with COVID have many aspects. To summarize them, people who have asthma and have COPD, who are using inhaled steroid, it is thought to be a protective mechanism from getting COVID by upregulating their receptors. As we said, the ACE2 receptors and all that. So it may have protection, even though there are studies after studies that failed to confirm the relationship. But the thought is maybe patients who have asthma and COPD who are already on steroid can have protective effect. Fast forward, giving steroid for people who are not already on it, especially systemic steroids, early in the disease or early in the infection with COVID may enhance the replication of virus and would have an ill effect on the patient. It may make him sicker. Instead of being from the 80% of people who have mild symptoms and go home, they might end up being from the 20% people who get worse and get into the hospital. However, late stage, when the fibrosis starts, as we showed in the first slide, there's an early phase of lung pneumonia and late stage. In early stage, you don't want to use steroid because you will increase replication. In late stage, when there's no live virus, but there is start and progress of fibrosis, that's where you need steroids. So in summary, people who are on steroids for asthma, COPD should not stop. It's not proven, but there might be a protective effect. People who just got infected with COVID should not be on steroid because that has a poor effect on the replication of the virus. So in early COVID pneumonia should not be on steroids. Late COVID pneumonia, when the virus replication stops, steroids should start. Next slide, please. Again. Sorry, I thought I had the control of this to try to make an effect, but this is the recovery style. Okay, you can stop here. The recovery is a big study in the UK that actually did not only include testing for dexamethasone. They looked into dexamethasone and colchicine, intelsimazab, and convalescent serum, and Regeneron, that's the antibodies that Trump took and claimed that it helped him, and on aspirin. So they looked at all 6 modalities, but I'm only going to talk about the low-dose dexamethasone. Next. Okay. I can barely see the slide, but I'll try to decipher this. So we have, this is the left upper slide, or the upper figure is showing the overall mortality improvement. The red line is the dexamethasone. The black line is the conventional treatment without prednisone. The second B slide shows a significant improvement. Those are the people who are on ventilators. So people on ventilators who get steroids have a significant improvement in mortality. The lower left is patients who are on oxygen only. And on the right lower is the people who are not on oxygen, AKA early in the disease. There is actually more mortality with dexamethasone. So this is a good description of the effect of steroids on COVID pneumonia. Next. Other way of looking at it, the right side line, it shows that no oxygen received. That's in the negative end of things. And the positive end of things are the either on ventilator way left, or in the middle, the patient are only on oxygen. So those are the people on the ventilator, or people who have increased the demand of oxygen. They should be on steroids as per the protocol. People who are not on oxygen should not be on steroids. As a matter of fact, steroid has an ill effect. Next slide. Next slide. After the initial study that published in the New England Journal from the British group, JAMA actually made a meta-analysis, and meta-analysis is comparing about 6 studies that tried to look at the same thing, and all of them concluded, or the meta-analysis at least concluded that there is a 20-day mortality improvement using the steroids as per the protocol. Next. Finally, I cannot conclude without talking about the vaccine, the one that is actually approved. Now there are 2 of them approved, the Pfizer and the Moderna. They act on the receptor, they stop the infection. As you can see in the cartoon there, there's a significant mortality, or significant, not mortality, significant